1970s, there were a lot of new technologies that made cardiac interventions for heart disease possible. Ironically, one of them being the defibrillator that he developed. And the logic was pretty simple. If an artery is blocked, you should open it. That's got to be good for you. There was sort of a paradigm of plumbing, but whether or not it actually helped patients, especially patients who were otherwise stable, really wasn't proven. And so Dr. Lown, thought it subjected people to unnecessary risks. So he started to question this. And when he tried at the Brigham actually to think about a trial, he found that as soon as somebody saw the results of the angiogram, it was nearly impossible to get anybody to consider medical therapy. So he made a brave and kind of risky decision. And that was for people with stable angina and coronary disease, he stopped sending them to the cath lab. So instead, his group, the group I joined in '84, managed everyone with optimal medical therapy with a real focus on lifestyle and particularly psychological factors. Now, at that time, this was a fairly radical thing to do, and Bernard was taking quite a risk, and he knew it. In fact, he told me he used to wake up at night worrying that just one bad outcome, one patient dropping dead, and he'd be run out of town, defrocked from Harvard and the Brigham, and he'd lose his license. But in fact, it didn't happen. And the methods that he used actually got very good results. Even though that was published in the New England Journal, it wasn't randomized and most people just didn't want to believe it. So when I started training with Dr. Lown in '84, we were doing this method essentially all the time. And as word got out, we were seeing a lot of second opinion patients. In fact, we published a series of a couple hundred, and in our hands, 85% of the time, people who'd been told they needed surgery or stenting, sometimes they had a surgical date on Friday and they came to us on a Monday or a Tuesday. 85% of the time we managed them medically and got really quite good results. So of course, 25 years later, we get a large prospective randomized trial, the COURAGE study, which essentially vindicated Dr. Lown's practice. And then another 10 years more recently, the ORBITA trial actually was quite a shocker. It showed that in people who are managed well medically, stenting doesn't actually do more than placebo. So in the end, I think, Dr. Lown's motto of doing as much as possible for the patient and as little as possible to the patient was really vindicated. However, even today, decades later, and many years after these trials have been published, stenting and revascularization for stable coronary disease remains active in the United States. And that's one of the measures we reported on. Shannon?
Thanks, Vikas. I'm Shannon Brownlee, and unfortunately, the story of unnecessary interventions is not limited to cardiology. Overuse is ubiquitous in healthcare. One study found that more than 40% of Medicare patients got at least one of 16 low-value services every year, putting them at unnecessary risk of serious complications, as well as financial and psychological harms. But overuse also wreaks havoc with the health system as a whole. As much as 1/3 of healthcare spending is wasted, and overuse contributes considerably to that waste. So when we created the Lown Hospitals Index, we wanted to follow in the path of Dr. Lown and do something that hadn't been done before, and that was a little bit brave. We evaluated individual hospitals based on their ability to avoid low-value services. Our hope is that by measuring overuse and making these data public, we can encourage hospitals to reduce potentially harmful unnecessary care, and actually all unnecessary care, and reward hospitals that are already taking that sort of Lownian approach of do as much for the patient and as little as possible to the patient. So we measured 12 low-value hospital services, including cardiac stents, diagnostic tests, back surgeries, and more. Vikas.
Sure. So the research on overuse that was just published in JAMA Open was based on data that we published last year in our rankings, and it just by coincidence got published this week. And so that has slightly different data set, but we're releasing today the new rankings, which are from 2016 to 2018. But here are a few key takeaways from the research. The first thing we found, as Shannon said, is that overuse in US hospitals is ubiquitous. We calculated that somewhere in the US, there's one low value service being performed every 80 seconds on average. Of course, some of these services are more widespread than others, and the most common ones were head imaging for syncope, which is fainting, blackouts, and the other was coronary stents. That's in total, but in terms of rates relative to the appropriate use of those services, some of these had even higher inappropriateness rates, and of those, nearly 2/3, for example, of hysterectomies were for benign conditions, and I think for stents, it was about 1/4 of all the stents that we saw were for stable disease without evidence of heart attack or unstable angina. The other thing we looked at was, characteristics of hospitals, and we saw that there are different types and different locations. So, for example, in the South, and in terms of for-profit hospitals, there was a greater tendency to see these low-value services. Major teaching hospitals actually tended to do better nationally on avoiding overuse, but even they struggled with two. One was coronary stenting, and the other was spinal fusion.
So we know you're eager to hear what our guests think about this topic. So let's introduce them. Michael Chernuh, PhD, is the Leonard D. Schaefer Professor of Healthcare Policy and the Director of Healthcare Markets and Regulation, the Healthcare Markets and Regulation Lab at Harvard Medical School. Dr. Chernuh's research examines several areas related to improving healthcare quality and value, and he's currently serving as the chair of the Medicare Payment Advisory Commission, commonly known as MedPAC, which advises Congress on Medicare payment issues.
And we have Dr. Rita Redberg, a cardiologist and professor of medicine at University of California, San Francisco, who's also at the Philip Lee Institute for Health Policy Studies. Dr. Redberg is the editor-in-chief of JAMA Internal Medicine and created the Less is More section of that journal, which highlights overuse research. She is also an expert in health technology assessment, as well as high-value care, and has served on MedPAC and given testimony to congressional committees multiple times.
And last but not least, Dr. Mark Smith is professor of clinical medicine at the University of California, San Francisco. He was the founding president and CEO of the California Healthcare Foundation, where he helped build the foundation into a recognized leader in delivery system innovation and public reporting of quality. He serves on several boards now, including the Institute for Healthcare Improvement, the Commonwealth Fund, Teladoc Health, Frisia, Jazz Pharmaceuticals, and the editorial board of Health Affairs. He's an internist, and he maintains an active clinical practice in HIV care at Zuckerberg San Francisco General Hospital. So thank you all for joining us, and take it away.
Great. So we're going to start with a question really for all of you. So maybe we'll just go in the order that we introduced you. Hospitals, hospital leadership, hospital administration will say and have said that these decisions about what treatments, what services to provide are not really under hospitals' control. So there's truth to that. The question is, what is the hospital's responsibility to reduce overuse? Is there any? And then to what extent is it the responsibility primarily of individual clinicians? Mike, what do you think?
So first, let me say I'm speaking on behalf of myself. I'm not speaking on behalf of MedPAC. That said, and I think actually largely due to Rita's time on MedPAC, we are very interested in the issues of low value care. Rita remembers. Rita's my low value care mentor. First of all, let me point out that the separation between hospitals and physicians is often artificial. Hospitals employ a lot of physicians. There's a lot of big delivery systems. Hospitals make a lot of decisions about what it takes to do certain procedures. They invest in equipment. They create a range of incentives for the physicians they employ. They create the burden or the lack thereof when people are encouraging things. They put in place policies around, for example, imaging prior to operations that influence what happens. So it's certainly true that hospitals can't flip a switch and change the way care is delivered. And it's certainly true that the hospital executives aren't the ones guiding individual care decisions. So that part is correct. But I don't think it's the case that hospitals have no control over the care that's delivered in their walls. And frankly, a lot of care delivered outside of their walls, given the move to outpatient care. So I think we will never be successful if we allow every stakeholder group to push responsibility off onto others, and that it really is going to be a combination of what hospitals do, the incentives they're given. I know you're going to ask about that, how the physicians practice, and really what we expect of our healthcare delivery system. And as long as hospitals are part of the healthcare delivery system, they have to be part of the solution.
Thanks, Mike. Rita?
Well, certainly I agree with everything that Michael said. And, while I would love to say I see my career in low value care ending, I think, unfortunately, it's only become more and more of an issue in the last 30 years I've been studying low value care. And absolutely, it's multifactorial. And obviously, hospitals do play a role as well as physicians. And, but for example, payment structure and profits of hospitals are built on a lot of very high margin procedures, and some of those high margin procedures are low value. And, we certainly saw that during the pandemic. Like spinal fusion, one of your examples, I believe, has not been shown to help patients, but it's a very well reimbursed and very lucrative procedure. And physicians are reimbursed according to how many procedures they do. And even in academic centers at major teaching hospitals, which clearly in your paper did better than other institutions and other types of hospitals, there's still a very clear incentive to do more highly reimbursed, but not necessarily high value procedures. And, part of that, is Medicare's reimbursement rates are set. Their procedures are reimbursed more highly. That is going to change a little bit. And even in evaluation and management, when I see a patient, if I order tests that they don't need, that's considered to be a higher value service, and you bill at a higher E&M, evaluation and management code, than if I didn't order tests that they may not need. So our whole system is and then the capacity of hospitals, when a hospital buys like a proton beam scanner, even though proton beam hasn't been shown to be better than other treatments for prostate cancer. And actually a lot of prostate cancer probably should never be treated because we do a lot of PSAs that shouldn't be ordered. But once a hospital invests a lot of money in a piece of equipment like a proton beam treatment, they're probably going to have an incentive to advertise that service and to use it, and the physicians will use it. So I think, as Michael said, hospitals play a role, and the way hospitals are kind of set up in terms of capacity and the way physicians are employed and paid by the hospitals play a role in incentivizing low value care. And of course, a lot of high value care, but we really have to separate those two.
You hit my bête noire, because the Washington, D.C. area has at least 5 proton beam machines between Baltimore and here in Northern Virginia. And they're all over the buses. Come get your proton beam. Being advertised for sure.
I think we did the math that area probably needs one, barely.
Barely.
So
yeah, for the whole mid-Atlantic region.
At least for the stuff that it's been proven to be useful for.
So Mark, what's your thoughts? Yeah, sorry. Because
well, first of all, I'd be great if I could get a proton beam next time I'm in Washington. Look, I agree with everything that Rita and Michael have said. I think there's some nuance here, though. Let's look at 2 institutions which are well known for having applied lean management to try to drive out waste, including unnecessary procedures. And they're Virginia Mason, you're going to have Gary Kaplan on later, and Theta Care in Appleton, Wisconsin. Virginia Mason is part of the Mayo Clinic diaspora. Its physicians are employed by the hospital. The hospital has substantial control over their activities, actually over their ability to be employed there, and has put in place kind of a physician compact that, among other things, incents physicians to deviate towards standard care. Theta Care, on the other hand, truly is the doctor's workshop, right? It's private community physicians. They're not employed by the hospital. That doesn't mean the hospital can't influence their actions, but I'm trying to say there's a wide range of relationships in American healthcare between hospitals and their associated physicians. Some are more tightly linked economically, some are employed, some are not. And there's a wide range of the existence of the kind of peer review and academic standards that I think leads to generally better performance in academic centers than in other kinds of hospitals on most of the measures that you've looked at. So there's a wide variety of relationships between hospitals and their associated doctors. But as Rita said, in the end, the hospital benefits generally from the performance of high margin procedures. And the high margin procedures are not necessarily high value procedures. So I think we've got to look to whatever the structural or economic relationship is, we've got to look to the role that that particular hospital can play in shepherding its associated physicians towards higher value care. One other thing I can't help but mention, and that is, as we've said, Rita and I were both involved in a study by the Institute of Medicine. 30% of all healthcare in America is of low value or no care, but it is devilishly difficult to know which 30% in advance. And we shouldn't overlook that fact. In addition, I think we often don't take into consideration some of the psychological benefit to patients from what we would, from an academic health services research perspective, define as wasted care. So if you look, for instance, at some of the things on your measure, should one get an EEG for syncope, right? Should one get a diagnostic test that involves radiation? It is easy to say, yes, we should reduce unnecessary radiation, and globally to a patient, we can argue correctly that we want to reduce the amount of radiation to the population and to you. But when you're in a situation as a clinician or a patient when it might be a bad thing, and the harm of the procedure, I'm not talking about an open lung biopsy, but I'm talking about an MRI of the back or an EEG for an elderly person who's fainted for the first time. It is often very difficult for me to figure out how you drive that waste to zero, because the value to the patient of knowing it's not a brain tumor or it's not something horrible with my heart is something that we haven't yet been able to quantify in our measure of waste. And I think you'll get pushback from a number of clinicians, rightly, that the number of normal EEGs and normal MRIs of the spine should not be zero, because there's a value to patients and clinicians alike for reassurance.
So Mark, I'm going to push back a little tiny bit on this, and I hope everybody else will jump in, which is that we found that almost all hospitals overuse these diagnostic tests like carotid imaging, head imaging, EEG.
Yep.
And certainly it's understandable that physicians want to get the right diagnosis. And certainly it's understandable that patients want reassurance. But at the same time, we know that this unnecessary testing can lead to a treatment cascade that doesn't just waste money and time, it also can lead to patient harm. And we haven't really quantified, not just we, but the research community hasn't quantified that all that well. But we know that it's not just the immediate harm of the test, like excess radiation. It's also what happens next, where you get that lung scan, and then, oh, there's a little something. And so then you get that lung biopsy, and oopsie, you got an infection from the biopsy. And oh, well, we got to go do a surgery. And this happens, and it doesn't happen 0 times. And it probably doesn't happen teeny amount of the time. It happens a lot, because surveys of physicians have said, yes, my patients go through the treatment cascade all the time. So there is harm.
Couldn't agree with you more. Mark Fendrick just wrote a piece about treatment cascades in the American Journal of Managed Care. So I couldn't agree. Let me tell you a personal story. My mother was one of the first people who got a spiral CT scan for being asymptomatic. They found something on there That led to a treatment cascade that led to a bronchoscopy, which was inconclusive. The inconclusive bronchoscopy led to an open lung biopsy, which in the end turned out to be, it was bupkis, in Yiddish, it was gornished. It was the little pencil. It stopped her from smoking, but that was a pretty expensive smoking cessation intervention. So I'm personally familiar with this kind of treatment cascade. Don't get me wrong. All I'm saying is I'm not sure we've got the right number about how many of these things are wasted. And I think Mark is onto something by saying we've got to first try to stop that cascade from beginning, but we've also got to have some gate points when something starts about, having done this, is it now really necessary to go on a bronchoscopy? Or if the bronchoscopy is inconclusive, is it now really necessary to go on to an open lung biopsy? So I agree with you. I've got some personal experience with it. I just think we have a difficult time factoring in the absolute in the moment clinical decision and the value to presenting something that may be rare, but would be serious if found.
Rita,
Well-
you are nodding vigorously. Go for it.
Well, because I love your story, Mark, and I think we won't have time for me to tell you all of the stories, for example, that we get at JAM Internal Medicine with people submitting to less is more, that a lot of them we can't even publish because it looks like malpractice, but this is what happened to patients. And it starts from that test. You know, one of our first less is more stories was from a cardiac CT test, that it was just to reassure the patient. And I won't tell you all the steps, but it ended up she had to have a heart transplant because of the complications from that cardiac CT in a healthy woman, just to reassure her. And so I think what we really have to get away from is this idea that a test can't hurt, and that you said patients like it, but patients don't like having unnecessary tests. What they like is feeling reassured and knowing that they're healthy. And what we have fed into is the idea that in order to reassure a patient and assure them that they're healthy, they have to have a test. You know, like Gil Welch says, you're only, you know, no one's healthy. Anyone who thinks they're healthy just hasn't had enough tests. You know, we just don't leave healthy people alone anymore. And it's very lucrative for hospitals and for physicians, but it's not really good for patients. And it's not good for us as a society, because now we're spending $4 trillion on healthcare, and we're not living the longest, we're not living the best, we don't have the lowest infant mortality rates. And I think it starts with this idea that a test can't hurt, and to reassure a patient, we should do a test. And that, oh, it's easier. And then once you do the test, you're like, you've gotten on a speeding train and you cannot get off that train. You know, you're going to get mowed down. And so I do think that's why, as Michael said, it's a big multifactorial process, because it's part of the medical culture, it's part of medical education. Our boards are all, you know, geared towards, we're graded on how many tests do we order. When I round in the hospital, you know, it's so much easier just to order an extra test than to think about why you didn't order a test. And so it really is going to take a multifactorial, multi-pronged cultural change. And I think we'll be better off for it, but it's going to take work.
One thing I want to throw in, you know, can't help channeling Bernard on this, which is a lot of what you're talking about, Mark, and what you're talking about, Rita, I think can be mitigated through kind of longitudinal relationship-based care. And I don't think we have enough of that, because a lot of what actually allows you to defer the cath, for example, or to defer certain kinds of tests where it's, you know, the probability is really low, is really the confidence, A, that, you know, this person, you know, has your back, B, that you can reach this person if you need to, C, that there's a follow-up plan in place to be sure that that small infinitesimal risk can actually be assessed. And if all of those pieces are in place, then it's a lot easier to stop that cascade very early on. So it really is an argument, as Rita's saying, for a broader cultural transformation in the sort of delivery of care and how we do it and what we expect of it.
So,
Mike, please.
What I was going to say is, I spent a lot of time talking about low value care, and that might have been one of the most thoughtful exchanges I've heard. So really thanks to Mark and Rita. I would say that the trick here is we're not going to make all low value care go away. The problem is we have a lot of things pushing in the same direction: financial incentives, cultural beliefs, benefit designs, medical liability, no one has mentioned, the way we pay. I think per Mark's comment on measurement, which is important, we really just need to start by doing better than where we are now, looking at variation. So the advantage of, for example, the piece that you published in JAMA Open, the rankings, is you're not saying go to zero. You're just showing there's some places that systematically do more than others. So while I agree, actually, there's a lot of reassurance, I think, going on, there's two problems. One is people want reassurance. They don't understand the cascade might follow. They're not told, if we find this, it's likely to be nothing, but if we find it, we're going to then have to do these 6 other things to you. So do you really want us to start looking for this? Because it might not work the way you want. So that's sort of one issue. And the other issue is we need to think through just the places that are doing a lot more of these than others, because I don't think the reassurance effector, whatever you think it is really varying that much across the different organizations. And when we know how the incentives are set up, for example, I think what we see, I think I can make the case that all low value care almost by definition is low value. If reassurance was that important and there weren't any harms, I don't think we should appropriately call it we shouldn't call it low value. And Mark's point is we don't capture that in the measures as well as we should. I agree with Mark's point on that. We need to understand sort of what the patients want. That being said, there's a lot of stuff out there that if you did the analysis perfectly, almost infeasibly, but perfectly, you would still end up with a lot of things are getting done because of the way people are educated, the way people are paid, and just the general culture. So instead of getting to zero low value care, let's just try and get the places that are doing more of it to do less of it. And it's going to be a continual process to do better. My basic.
So Mike, let me take you up on something you anticipated earlier on, which is, let's talk a little bit about payment. I mean, lots of people like to focus on that. It's not the only arrow in the quiver, but I suspect it's a big one. So my question really is, what do you think would be a sufficient kind of payment paradigm to really reduce low value care without simultaneously, if it's possible, incentivizing skimping on care? Do you have a model or do you have a framework?
First of all, obviously not. And so I feel like I should sign off. You know, Mark's done this, so you should talk to him. But my general sense is we want to move to the extent possible away from such micro fee-for-service stuff we're doing. I think because low value care is so nuanced, it's going to be very hard to do, you know, do not pay kind of things, because many of the care that is low value is also high value. Mark Fendrick, a very close colleague of mine and co-editor of the American Journal of Managed Care, by the way, will say colonoscopy is his favorite high value and favorite low value service. It all depends on sort of who gets it and where. One thing I've learned as an economist is the human body is even more complex. You know, I thought there was like, you know, head, shoulder, knees, and toes. Turns out there's a lot of body parts, a lot of medicine's kind of complex. We're not going to be able to do that micro payment, but moving away from fee-for-service towards broader payment models like episode payments or population-based payments, which I tend to like, is a start in various ways. There's a lot of complexities with doing that, so I don't want people to start putting in the chat how I'm naive about what they can do. I understand their complexities, but I think they help move us in that direction. And then there needs to be a lot of improvement on aspects of quality measurement, not just incorporating low value care like you're doing in your report card in terms of quality measures, but also stenting, like you mentioned. When are people not getting what they want? We are never going to, again, I'm old enough that I've lost whatever idealism I had that we're going to make the system perfect. We just have to move it further along. Dan Wolfson, who many of you may know, who's really been a leader in choosing wisely, which is the basis for a lot of the stuff, puts a lot of emphasis on professionalism. I think what he would say, and I hope he's on the Zoom, is that professionalism is very, very important. It helps with prevent stenting. It helps in a range of ways. It's not sufficient simply to publish the Choosing Wisely list and expect professionalism alone is going to get rid of all the low value care. So we have to begin to modify payment models where we can, recognizing their limitations, to eliminate some of the things. And again, I think Mark said this, measure aspects of these things. And the last thing I'll say before I give up the floor, although I don't know if you have a floor in these Zoom calls, but when I give it up, I really think if I could pick one thing to do, and I'd love people to send me emails or otherwise, I would like to get employers engaged in this. I think the commercial sector and employers in general have not been quite as engaged. There's a lot of reasons why this is hard to engage specifically in Medicare. There's a lot of reasons why it's hard to engage in Medicaid. There are payment reform areas in both of those spaces, but I think in the commercial sector, employers could do a lot more, and I'd like to get them more engaged in how they pay for and incent care of all types, including high and low value care.
So
Thanks,
I know
Mike.
Mark, sorry, I know Mark's going to have an opinion about global budgeting for hospitals, this sort of population based, but I'd like both Mark and Rita to think about the two pieces of this, which is there's the global budgeting of hospitals, but there's the salarying of physicians, which we see very clear differences in behavior in these salary group practices versus, you know, fee for service. The physician is fee for service and the hospital's fee for service. So Mark, please take the floor for a moment. You're on mute.
Thank you for unmuting me. Yeah, I think, well, let me relate it to something that Vikas said. I think this point of kind of longitudinal care is really important because, and I hope you'll ask Gary about this. Often I think the answer is not just, we're not going to do A, but we're going to do B instead, because you came to me with a problem. You came to me with an issue, with a symptom, with something. And when the answer, particularly if it's a transactional circumstance, like in an emergency room, right? If the answer is no, we're not going to do the scan, that's where you kind of get this bang. If, on the other hand, one has a longitudinal relationship that has all the trust and all the things that Vikas talked about, and or you can say to someone, no, we're not going to do an MRI on your back, but we are, having screened you for something that's acute and dangerous, we're going to send you to PT, wait for it, today, right? Because the evidence suggests that PT will be more effective immediately than sending you for an MRI, getting a negative result, and then scheduling you 5 days from now. I think often the answer here is involves not just kind of an attitude, but having systematic ways of dealing with these issues. I'm sure that Peter and Gary can speak to them. So how you pay physicians, I think, depends often on kind of what the background is. In our work with the LAN, it turns out that for doctors who are coming from a pure fee-for-service, eat-what-you-kill community environment, kind of giving them individual financial incentives to adhere to high-value kind of algorithms was successful. For doctors who were in Kaiser, when they thought they should do that, it turned out to backfire because they said, wait a minute, we're already kind of trying to practice high quality care. And the next time they had an experiment, people said, well, why don't you pay me for this improvement in my practice? So again, there's nuance here. I'd like to think that we'd like to move towards a situation in which all the professionals are in an organization that can help them both educationally and with system prompts, system education, system alternatives to that easy, do the test, get the MRI. But it depends in part on where you're coming from. Again, there's great heterogeneity in where we are now, and the right solution for one group may or may not be the right solution for another. Again, I'd be interested to see what Peter and Gary have to say about this.
Rita, any thoughts about this?
Oh, sure. So, I mean, I agree with what Mark and Michael have said, but I do think there are a lot of problems in fee-for-service. I mean, fee-for-service rewards volume, and we have by far the highest volume system in the world, and it rewards volume without any regard to value. So while I don't think getting rid of fee-for-service would solve all of our problems, it would be a good start. I also do think it's in the culture of medicine, as we've talked about. You know, when like more than 10 years ago now, I did focus groups with Grace Lynn, one of my UCSF colleagues, and Adam Stubbsley, and we talked to groups of internists separately from groups of cardiologists, because we didn't think the internists would get a word in edgewise if we mixed them with the cardiologists. And, you know, from all different systems, including capitated systems, about basically a case study of a patient I had actually seen an unnecessary PCI. And, they pretty much all said the same thing, even in the capitated system, because it's part of the culture too. It's not just, that all, as you said, Shannon, all of the incentives go toward doing something. The doctors would say patients want it, but of course patients want what we tell them. Doctors are clearly the power part of that doctor-patient relationship. And if I told the patient, we could do this procedure on you, it'll open your artery, but you have no more chance of living longer, you have no more chance of avoiding a heart attack, and you do have a risk of bleeding, you get radiation, you could have contrast reaction, and you're no better off, they might make a different decision. So it's not like patients want it. They want it because for reasons that are not true, and we don't dissuade them of their belief that it will make them live longer. In that case for PCI, but in other cases too. And then, as I said, there's also the capacity issue. So we've built in a lot of excess capacity, and then we generate demand for this excess capacity. So we have more CT scanners, more MRI machines, more proton beam machines than anywhere else in the world. And then we build in cases for use for these things.
So if I can jump in, I want to be clear. I don't believe I am an economist, which is a little self-deprecating, but I don't believe that physicians are, or at least many physicians are running around thinking, boy, this is an extra however many dollars if they order this test or not. I don't believe it is nearly that explicit in what's going on. I believe there's just a culture of the way medicine is practiced. There's a lack of attention to low value care. There's because it is sometimes high margin, there's less of an incentive for anyone to decide to really go after it. Because if you're trying to say, I could spend a lot of money on some initiative, why do you want to spend money on an initiative where eventually you're going to lose money one way or another? So I think these things all play into what is going on, which is why I believe the exercise you've done in terms of measurement, at the core of what we're here to talk about today, or maybe what you're here to talk about today, is the measurement activity you did. And the advantage of that is it shines a light and attention on an area that's important that otherwise might not be in the light. And so that sort of measurement and comparison ends up being important because I am not the type of economist that believes that if we change payment, things would melt away. If low value care melted away in ACOs, the ACO evaluations would be much, much more positive on ACOs, right? It is all that they do is they remove a barrier to going after this because they take out the financial loss associated with it, but they do not push people to change the culture particularly. They don't shine the light necessarily themselves on these things. They just help you make the case if you're going to go after them. That's why we need the payers, public and private, to begin to do this, and we need other folks to begin to measure this because it is going to take a while to move the needle a little bit. And so, Rita, you'll still be doing low value care.
Okay.
So I'm going to pivot a little bit based on what you said, Mike. But before I do, I just want to point out I may have the dubious distinction of being the only one on this panel who spent 100% of many years in a community hospital in private practice. And I can tell you, Mike, with all due respect, that in general, people in academia tend to discount the role of the money in the culture. But you're right, it's not on any given day. It's not about, today I'm going to, it's not like that. But there's a general sense, it's like they say in Silicon Valley, it's a way of keeping score. And, I think that element shouldn't be discounted as we think about the real world. But having said that, I want to just ask, based on what you just said, Mike, I'm going to guess, but maybe I'm wrong. And for each of you, does what we're doing, and in general, does public ranking and reporting have utility? Because I'm aware that in some ways, report cards have done nothing. So I think, there'd be a case to be made that this is really not the way to go. On the other hand, we at the Lown Institute have made a decision that there is value in terms of triggering a conversation, but what those next steps are and how we actually go to the next step, I think is an important conversation we all have to have. So maybe we'll just go down the batting order again, Mike.
So I agree with everything you said. I'll just say when we started doing this, I worked with some colleagues of mine, Aaron Schwartz and Michael McWilliams, and we did some measures. We published some stuff in Medicare. We made it free online, the codes that we had to do. I thought it was all going to work magically. We ended up partnering with a company called Milliman. And so just in full disclosure, I have a relationship with Milliman and Mark Fendrick on something called the Health Waste Calculator, which helped measure this. I think essentially we've tried to begin to build a business case around measurement, not simply to report, although I do think what you've done is important, but a tool for insurers and employers to see what's going on explicitly. The work now that I'm trying to get off the ground involves engaging employers to more explicitly reduce the incentives of what they will pay, at least on the administrative costs on top of the low value care. So I think there's a lot to be said for measurement. I think there's some value of what you've done in starting the conversation, but you need, when you look at those institutions, to ask the people that are paying for that low value care that you've identified, why are you paying for it? Now, some of it's in Medicare, and I'm not going to talk a lot about why Medicare does what Medicare does, although I would really like to. I'm not going to. Rita or Mark can. But there's some really unique challenges in Medicare to do this. But in the commercial sector, you could be much more aggressive once you see this type of thing. And the trick now is moving to the commercial sector, and the entire infrastructure we've built in the commercial sector, the employee benefit consulting firms, the employers, the TPAs, the carriers, to think through how to get the attention on this. And I will say many major carriers I know are beginning to think about this and starting with measurement. And I think that matters. And I will say, without the measurement, without choosing wisely, we again, I know that Dan's listening, but I mean this part sincerely. Maybe he's got it off and he doesn't realize. We would be nowhere in this discussion without the beginning of measurement nationally. And we would not have been able to make any progress without recognition that there's variation, because otherwise people would have attacked the measure. The whole Wenberg variation stuff from the beginning enables a conversation that hopefully will engage people to try and reduce low value care. And I should say, I know I'm an economist, not just for the money, but for the adverse consequences to patients when they get adverse treatments and effects. There's no one that really, broadly speaking, will defend low value care once you convince them it's low value. It costs money and it's bad for people. It's just a question of measuring that, given all the nuances, and finding the right strategies to go after it I would say, a way that's respectful of the clinical autonomy that has to exist between patients and their providers. I don't think this is ever going to be a cookbook solution because body's too complicated, people's preferences are too complicated. We're going to have to move in a way that recognizes that aspect of care delivery.
Great. Well, we're slowly running out of time. So Rita, I'll give you the floor. And I see Dan Wilson just threw into the chat that public reporting is a good first step, but who's listening and then who's acting on the information?
Right. Those are all good points. I'll say that I think, well, first of all, about inappropriate care. I mean, I've been at many medical conferences over many years where, there'll be a question, who thinks in the audience, and hundreds of doctors sitting in the audience, who thinks that inappropriate care is practiced? And everybody raises their hand. Then who thinks they practice inappropriate care? And nobody raises their hand. So, I mean, clearly this is happening, and why it's happening, there are a lot of reasons, and we've been talking about them. But measurement and report cards in a lot of ways will help, but it's some question of, like in California, we have public reporting for PCI and cabbage, but there are a lot of nuances to how that gets reported and how it's used. There are, doctors, certainly we all respond to report cards. That's how, we got to medical school and all that, but it depends on, right now, really you get rewarded more for doing more than you do for, avoiding low value care. You can also, there are lots of ways of measurement. We should change the boards, the ABIM. The questions are really geared towards things you do, not towards things that you shouldn't do. And in our whole medical education system, we really don't talk about the problem of overuse. We talk a lot about underuse, and that's appropriate, but we don't talk about overuse, and it's not balanced at all. US News and World Report rankings, I think, could look at hospitals and acknowledge, overuse and mark people down. Hospitals are very, very concerned about their rankings. Doctors are concerned about their rankings, but particularly when it's tied to other things like reimbursement and just professionalism. I mean, doctors do care about professionalism. I think, it's still a helping profession. We went in to help, but I think the culture has just changed to not focusing on how we're harming patients from overuse. So I think there are a lot of ways we could reduce overuse.
Great. We're running out of time. I'm going to, Mark, I'm going to turn to a couple of questions from the audience. I'm just going to rattle them off, and then you can feel free to respond to whichever ones move you the most. So Paul Haddis pointed out that in Maryland, which was near the bottom of our rankings of avoiding overuse, even though hospitals are on annual budgets. On the other hand, doctors are still fee-for-service there. So any thoughts about the Maryland situation and whether the disjunction between hospitals and physician payment might be an important thing to focus on? Also, what about the role of RVUs in particular to pay for physicians? Is that, strictly speaking, purely a volume thing or not? And does the coding culture itself, Leah Binder asks, does the coding culture itself contribute to inappropriate care, just the act of the coding and how we do it? And from, I think, a lot of patient advocates would want to know, what role do patients have in avoiding low value care? How can they do it? And can shared decision-making be used more and better? So Mark, there's a potpourri.
Well, that's quite a potpourri of questions. First of all, I think a number of them have to do with the point that Michael made, which is as long as we're in this kind of micro units of service measurement, we're in a constant arms race between providers and plans about how many did you do and was it necessary and this and that. So I'm in general in favor of invoking providers' involvement in and skin in the game in reducing costs and reducing unnecessary care. I respect deeply the hospital leaders you have on this call and all of my colleagues who run hospitals. I'm deeply troubled by the notion that you would put a hospital in charge of a budget of health of people in a certain geographic area. My sense is all these cultural issues that we've talked about, the capital investments that have to be amortized, their deep commitment to the bricks and mortar that make most hospitals go, make them a difficult partner, a difficult maestro of these arrangements. I think they're important partners, but I think I would not put them in charge, particularly when we haven't talked about the overuse of hospitalization in general. That is to say, how many people go in a hospital, how many of them there because of inadequacy of ambulatory care, et cetera. So
it speaks to the capacity problem that Jack Wenberg pointed out a long time ago.
It does.
Yep.
So let me just finish with this, because I think the measurement issue that you're doing is extremely important. Shining a light on overuse and is extremely important. I think we still haven't found the right actor to use this tool effectively. And I would love to see employers do more, but in general, I think people in the provider and world overestimate the ability of and the interest of employers in mucking about in the details in the healthcare system. It's not what they know. It's not where they make their money. They are largely beholden to the activities of the plans to whom they delegate much of this activity. And while there are some interesting and exciting things happening, in general, it's one of these cases where everybody in healthcare thinks that somebody else is really in charge. And the fact is nobody's entirely in charge. There's got to be some coming together of interest here. So I think employers and government and watchdogs and plans who know more than anybody else about this in detail, but whose capacity to work on it aggressively is limited, frankly, for both economic and political reasons. I think that's where the big collaboration could use the kinds of reports that you're beginning to produce to affect a change.
Thank you, Mark, and thank you to all of you, to our guests, Mike Chernuh, Rita Redberg, and you're welcome to stay, though I know several of you have to head out, but we're now going to turn to the second half of the program. it's time to reveal those hospitals that did really well. We're going to talk about the top 10 for avoiding overuse in the Lown Index this year. So these are the top hospitals for avoiding overuse. And the notable thing, I think, is that they're not necessarily, or in all cases, the most well-known institutions in the country. In fact, they tend to be more regional providers. And then some of what we saw and pointed out in the JAMA paper, what you'll see is there's an absence of hospitals from the southern United States. But here they are: Scott County Hospital in Scott City, Kansas; Beth Israel Deaconess Hospital in Boston; West River Regional Medical Center in North Dakota; Highland Hospital in Rochester, New York; Mayo Clinic Health System in Lake City, Minnesota; Maine Medical Center in Portland; Sydney Regional Medical Center in Nebraska; Mary Hitchcock Hospital in Lebanon; Healdsburg District Hospital in Healdsburg, California; and Contra Costa Regional Medical Center in Martinez, California. There they are.
Thanks, Vikas. So we mentioned that the hospitals that we generally see at the top of the US News rankings did not make it into the top 10, our top 10 for avoiding overuse. So how did those hospitals do? The Cleveland Clinic, which is often in the honor roll of US News, Best Hospitals in America, was the only hospital in that honor roll to break into the Lown Top 100. Most others placed in the top third, but there were a few outliers like Houston Methodist and NYU Langone Medical Center that are both in the top hospitals in US News that really didn't do as well. So there are also some pretty significant regional differences in the ranking as well. Generally, states in New England and the Pacific Northwest do best on overuse. Their hospitals do best on overuse, with Vermont, Maine, and Oregon at the top. On the other hand, the southern region was home to 41 of the 50 lowest performing hospitals, with 5 of the bottom 10 located in Florida. And I won't tell you the joke about Florida and medicine.
All right.
Because.
Thank you. So we're now excited to introduce 2 leaders of hospital systems that did particularly well. We're going to ask them some questions. First, Peter Healey, who joined the Beth Israel Deaconess Medical Center as president in 2017. In his role, he worked with the senior management team in the Harvard Medical Faculty Practice to strengthen clinical operations, academic achievement, and the BIDMC experience. He also served as president and CEO of Beth Israel Deaconess Milton before that. And Milton was one of the fastest growing community hospitals in the state and earned national recognition for healthcare quality. Peter has more than 25 years experience in hospital leadership in the greater Boston area, including key roles at Boston Medical Center and Brigham and Women's Faulkner Hospital.
And Gary Kaplan is currently CEO of Virginia Mason Franciscan Health and Senior Vice President of the Common Spirit Health System. This is in Seattle. Gary served as chairman and CEO of Virginia Mason Health System from 2000 to January 2021. He's also a practicing internal medicine physician at Virginia Mason. And during his tenure, Virginia Mason has received considerable national and international praise for its efforts to transform the delivery of care in that hospital, most notably as one of the leaders in adapting the Toyota production system for healthcare. Virginia Mason has consistently been named a top hospital by Leapfrog and was a top hospital of the decade in 2010. In addition, Virginia Mason is the only Washington state hospital to earn an A patient safety grade every year since the grading system began.
So let's start. So Peter, the BI Deaconess really had impressive overuse scores. I mean, #2 in the nation and multiple top 100s across multiple services. So the obvious first question is, what do you think contributed to that success? And, you know, in particular, were there specific initiatives, capacity? How did this happen?
Sure. Well, thanks for inviting me and inviting us at BIDMC to participate. So there were a number of things, and I guess I would say the good news and the bad news, depending on how you look at it. It was not because we were particularly focused on reducing overuse. So it's not like we rose to the top of the list because it was our major goal or strategy. Now, I think you can look at that as good news because the other things that we did by trying to do what we thought was best for this organization in our system within Beth Israel Lahey Health is, and some other just factors that are part of our existence, I think led to where we are. So I guess the good news is you can improve in this area without specifically working on it, but doing the right thing for other reasons. And I think for us, one is we are part of a system that covers Eastern Massachusetts. So there was a comment about the hospitals that are more regional tend to do better, and we are regional for our system. So we are the major academic medical center based in Boston within Beth Israel Lahey Health, and we have 13 other entities. And our philosophy as a system is to provide the right care in the right place at the right time. And that really means for us keeping care in the community whenever possible. That has really become that's our strategy because we do think that's the right thing to do. And we think care should be provided as close to home as possible. And these days it's more and more happening in the home, and that will continue to grow. And then folks should stay with a local primary care physician and a local hospital, and really only end up with us when they have the kinds of needs that can't be provided in the community. One of the factors that we have that necessitates that, in addition to us thinking it's the right thing to do, is capacity. We have a lot of challenge with our capacity. We're very busy, we're very full, and we're constantly looking to use our capacity towards those things that only a tertiary quaternary center can do, and not to be doing things here and using our kind of very expensive real estate and resources to provide routine care that can be provided elsewhere. So I'm sure we'll touch on some other things, but those are a couple of the major driving factors.
Pete,
Great, thank you. Yeah,
sorry,
we'll dive in, but
yeah.
let's keep going. Shannon.
Yeah. So Gary, you guys really are really well known for the work that you've done using the Toyota Kaizen process, and you've been to, for the last 20 years, you've been taking trips to Japan to learn this process. So you've made a significant investment. The process focuses on efficiency and delivery of care as safely as possible with minimal use of resources, labor, and patient time, which is incredibly important. But as you've said yourself, you can deliver a medical service incredibly efficiently and incredibly safely, and it's still the wrong thing to give to that patient. So what prompted Virginia Mason to make reducing overuse part of your quality process?
Well, thank you for having me on this panel, and for your leadership in bringing these issues forward. This has been something we've been passionate about at Virginia Mason now for 2 decades. And I think it really did start with our discovery of the Toyota production system, or what some call lean management, as applicable to healthcare. And when we began to learn about it, we came to the realization that in healthcare, we make things. We make office visits, we make surgical procedures, we make lab tests, we make bills. And when you think about making things, it forces you to think about the processes that go into making those things. And when you do that, the waste becomes so visible. And so early in this journey, we realized that not only was there waste of waiting, administrative waste, but really a ton of waste in clinical care delivery. And it really was brought home to us in 2004, where we'd already been 2.5 years on this journey, when Aetna and Starbucks came to us and said, your pathway for low back pain, or how you treat low back pain patients, is much too costly. And we said, whoa, that's not what we want to be about. Let us delve into this. And what we saw was the overuse of MRIs. It became very visible to us. And we realized that 50% of patients with back pain for more than a week were getting MRIs, and only 1% of those actually needed it. And you could identify those people more often than not up front because of their associated symptoms. And our clinicians said, how can we be serious about taking waste out of processes if we're providing low value care, if we're doing things that add no value? So way back then, we put appropriateness into our definition of quality. Then, as now, not by choice, we are still almost 100% fee-for-service delivery system. And so it became deeply embedded in our mindset and our way of thinking. And evidence-based medicine has become so much more prevalent. I think one of the interesting things that came up, though, in this journey is, well, if there's really only high quality evidence, randomized controlled trials for perhaps a third of what we do, is the absence of evidence a license for variation? Does it really say it's okay to do it anyway because there's no evidence to the contrary? And we actually said that actually creates a defect prone situation. And so we even began to standardize processes and care delivery pathways, we're talking 15 years ago, in areas where there was no evidence, but we can't improve what we can't measure, and we couldn't measure something that was done 10 different ways. So we standardized so we could measure and potentially begin to create evidence in some of these areas. So it's deeply embedded in our culture. Early on, we put decision support tools into our EMR, so that I, as a primary care internist, could not order an MRI for a patient with back pain unless there were certain criteria met. I initially thought, as a leader, that our doctors would kind of, be very resistant to this. I kind of thought they'd kind of go nuts over this, that we were actually embedding this into the decision support. And quite the contrary, it became an asset, a tool for how we could relate to our patients and say, come over here, let's look at this together. You don't have lateralizing findings. You don't have bowel or bladder incontinence. You don't have the things that would say we need to do an advanced imaging and procedure, exposure to radiation, et cetera. And so those kinds of approaches have served us very well, and it's now, many, many years later, deeply embedded in our culture.
Thank you. We have a nice comment from Patty Gabow, who's the former CEO of Denver Health, the biggest safety net hospital in Denver,
Totally.
Yeah, and also the chairman of the board of the Lown Institute. And Patty says, lean is also about respect for people. And we always said waste is disrespectful to patients because you're asking them to endure processes and procedures that were unnecessary. It's a nice addition to what
I would add, it's disrespectful to staff. People do not want to come to work to do things that potentially harm patients without indications.
I think that's underestimated a lot, that the effect on patients, on clinicians, of doing things that they don't think that the patient really needs can be pretty hard as well. So Pete, hospitals in the Northeast do particularly well at avoiding overuse compared to other regions. Why do you think that might be? What is there's something cultural, something in the air, something in the water? What's going on?
Yeah, I don't think so. I mean, there are definitely some differences about New England, but I think it's really more just kind of the conditions that exist here that may not exist in other parts of the country. When thinking about the map that you put up there, if I think about kind of the Minnesota area, New England, the upper Northwest, one of the things that those markets would have in common is they're probably the most mature managed care markets in the country. They've all been in managed care type work, kind of original HMOs going back to the 90s. So I think the insurance markets are very different. Specifically in Massachusetts, there's basically three payers, private payers in Massachusetts: Harvard Pilgrim, Tufts Health Plan, and Blue Cross. And those three payers have fairly mature, although I would say kind of stunted at this time, but fairly mature managed care methods. And we are involved in risk sharing contracts where total medical expense is something that we can be rewarded or penalized on. It's still, fee for service is really still the major source of revenue, but it is total medical expense is a measure and can be a penalty and can be a reward. And so when you look at how much of our work is really subject to these risk payer agreements, it's pretty substantial. So I think that's a unique piece of New England. I also think, again, this is, I think, largely across New England, but specifically in Massachusetts, we're pretty highly regulated in that there's determination of need required for major imaging expansion, surgery center expansion. There's a focus on controlling growth, because we know that when there's more capacity, it tends to get used, and then also tends to get used unnecessarily as well. So it's a more regulated state. And we were the first state to implement what was Romney Care, but it's basically, as much as it was hotly debated during the election, it's the same thing as Obamacare. And so we had that back in 2006. We have a healthcare cost commission that was developed along with that, and we have a healthcare inflation target or limit statewide every year that gets tracked. So I think there's a number of things that kind of push down on overuse and overexpansion in Boston and in New England, perhaps more so than other parts of the country.
Interesting. I mean, one of the arguments that the Dartmouth group has made is that when you have a very high capacity for your per capita capacity for beds, for example, you get more hospitalizations, et cetera. And in some ways, what's happened in Massachusetts may be that you've had an expanded population of insured patients without having a concomitant expansion of capacity. And so it's forced everybody to sort of be a little bit more judicious in when they hospitalize, what testing they're using, et cetera.
I think that's part of it. I mean, we have a very low underinsured rate in Massachusetts. It's less than 5%.
Mm-hmm.
So Gary, you heard, I think you may have been on, I'm not sure if you were on when Mike and Rita were talking about changes in payment methodologies. Obviously, this is a perennial question. So I was actually quite surprised, though I should have known, when you mentioned on an earlier call that the work you did at Virginia Mason, all of these efforts and all these improvements were really done within a fee-for-service environment. And so I'm just curious whether or not you faced, the sort of classic trade-offs of having to essentially plan for a reduction of revenue, or how you manage that process. And then what's the obstacle to going to a more managed care model and maybe even accelerating everything even further using some kind of value-based payment system? Tell us about Seattle.
So interesting, numerous aspects to that question. And again, I'd go back to the low back pain work that we were very heavily engaged in. I know Shannon was very familiar with it back then. And in the Health Affairs article where Mayfam and others wrote about it, it was, well, Aetna did better, Starbucks did better, and Virginia Mason lost their shirt because of eliminating the only profitable aspect of the low back pain pathway being MRIs. But the reality was that it enabled us to go to the payers to talk about incentivizing physical therapy to improve our payment rates, to not have to order the next MRI machine as rapidly, to actually create increased throughput and reduce the amount of space we needed. So that was the beginning of coming to realize that we could create a business model around appropriateness. That then led us to centers of excellence work, where we were chosen as one of the only 3 complex spine centers for Walmart, the Pacific Business Group on Health, and certain domains. So I'm not here to say that we didn't necessarily disadvantage ourselves by appropriateness. I think there was top line revenue reductions, but we worked hard to try to find the pathway to create a business model towards it. And I think the number one factor, though, that allowed us to succeed has already been discussed a couple times. Peter mentioned it as well, which is capacity. We deliberately did not build over capacity. We did not add excess beds. We did not add excess advanced imaging equipment. I think in some ways being a bit capital constrained as a solitary independent hospital in those years allowed us to and facilitated our avoiding overbuilding capacity. And I think that was a major factor. I think in terms of barriers, there are several. And I think capacity is one of them. We have overcapacity in our healthcare arena today, and many hospital CEOs are focused on how do I fill my beds? That's the number one thing you look at in the morning is your occupancy rates. And so I think overcapacity is a big issue. I think the payers are not necessarily our friends in this regard. It's market specific, payer specific. We have 2 major Blues plans in this part of the country in Washington State. Both of them have been over time, and hopefully this will change, reluctant to shift risk, to allow more provider risk, to realign incentives, and the status quo payment models have been very much reinforced. We have a heavily brokered community where 90% of employer-sponsored healthcare is purchased through employee benefit intermediaries who also have a stake in preserving the status quo. So I think there's lots of structural barriers. But as I said earlier when we were talking about this, the one thing I want to emphasize and appeal to our listeners, there are many people like me and Pete who get up there and they say, woe is us. I got 1 foot on the dock and 1 foot in the boat, or 1 foot in the pay for volume canoe and 1 foot in the pay for value canoe. I just don't know which way to go. And I find that questionably, ethically questionable. I find it almost morally bankrupt. It's basically saying until you pay us differently, we're going to keep ordering unnecessary tests, doing unnecessary procedures. And I don't think that's what we want to be about as a profession. So if I can make only one point, I think professionalism, and Rita brought this up, should drive us to embedding appropriateness in every clinical decision we make. And that's what we've tried to do at Virginia Mason. It's an uphill battle without the payment environment changing, but I think we've shown how you can make headway despite the predominance of fee-for-service in any given market.
Thanks, Gary. Follow-up to both of you really is thinking about your own clinical community. I'm kind of on both sides of the fence, as it were. How can clinicians actually support efforts of leadership to really, damp down, to really reduce and eliminate low-value care? And, the flip is, what's your experience been, and how do you manage situations where it becomes really a bone of contention?
Well,
Pete,
maybe
why don't
I'll
I
start.
with you?
Well, I'll start kind of adding to what Gary was saying about that, issue of payment driving what we should do. I agree with him, maybe from a different perspective. I know that in my career, I have not spent a lot of time focusing on, what things we do bring in the most money and what things we do lose money. We have plenty of each. We have lots of things that we can make a margin on, lots of things we will never make a margin on. And that's, one of the challenges is institutions need to stay afloat, and they need to figure out where they can generate enough revenue so they can cover the things that are not going to cover themselves. But I've always thought that that was a trap of sorts, that if you started kind of tracking those things and paying most attention and making most of the investments in those things where you generated the most revenue, the reality is they change. And, I've always thought that, or I came to learn, I guess I should say, that you should not fight innovation in healthcare, that innovation is going to happen. And that a lot of innovation, at least over the last, 20 plus years, has been about moving care from inpatient to outpatient, moving care from the OR to a procedure, from a procedure to a pill. It generally less invasive, not always less expensive, but with patient safety and quality in mind. And if you build an institution around just those things that generate excess revenue, like major imaging or procedures or other things that tend to be connected to overuse, you've created a false economy for yourself, and the bottom is going to come out at some point, and you're going to end up in trouble. So my focus has always been, and I've worked half my career in community hospitals, half in academic medical centers, is on what do our patients need and what are we here to provide. And so at BIDMC, we're here to provide the tertiary quaternary care. And so when somebody comes to me and says, we can really do well if we do more sleep studies, I say, we're not really going to dedicate space in the Longwood medical area for doing sleep studies. There probably is a place in the system where that could or should happen. Maybe people can have their sleep studies at home, but we need to use our resources for those things that patients need and that we have the assembled expertise and ability to provide. So that's how I've kind of approached it, is not wanting to contribute to, or play into, or get caught by these things that turn into be false economies.
I would totally agree with Peter, and now as part of and co-leading a much bigger system, I think how we rationalize services, where they're provided, makes a lot of sense, and that low value care, frankly, shouldn't be provided anywhere in the system. As I think about this, in the last 2 decades of our work at Virginia Mason has really been about deploying systems engineering principles to healthcare, and I think they're definitely directly applicable. And Patty and others have helped show the way. And what that requires then is a deep understanding of our care processes. So from the clinician standpoint, our clinicians today understand the workflows and the evidence for each of the things they do. That's part of deploying what we call our management system, not just our quality improvement method, but our management system to day-to-day clinical care. And so it gives our clinicians tools to hopefully most of the time, and we do audit these things because it's critically important that we understand how well we're doing on not providing low value care. It gives them the tools that allow them to understand their processes and the evidence and their clinical choices so that they can make the right decisions on behalf of their patients. Standardization of non-value added variation is critically important, but it also means that then you are able to customize for each individual patient. So a lot of people who don't understand lean think it's just standardize everything and cookbook medicine. And in fact, it really is about standardizing where value where there is no value to the variation, and then allowing value-added variation to be based on a particular patient's needs. And so those are the kinds of things we work closely with our clinicians on day in and day out.
Thank you. Thank you both. We have some questions from the audience. Shannon, you want to grab one?
Sure. So, you know, there's been something in the papers recently about sort of pent-up demand for elective surgeries post-COVID, and the demands on both sides of the table. Patients feel like they need to go in and get things, and hospitals seem fairly eager. Do you want to talk a little bit about that vis-a-vis overuse? Either one of you, both of you. Peter, please go ahead, and then Gary.
Right, and I see the question from Paul Haddis, and I think that's Paul Haddis from here in Massachusetts. So there was legitimate pent-up demand. We postponed surgeries for months, and there were really, challenging issues with patients that have been waiting and they're in pain and they were scheduled, and we had to postpone. We shut down through the first surge, which was very significant in Boston. And then we got, we were able to catch up of some in the summer, and then we had to shut down again. Certain hospitals had to shut down more than others, but we had to shut down elective surgery again. And so there's a lot of challenge with patients that had, legitimate needs for procedures that had to be delayed and postponed. And so, yeah, we're seeing, we're very busy right now with a lot of volume that was legitimate pent up demand. And we've seen issues in cancer and cardiac and others were things that were not addressed during COVID. So I think that's legitimate. But the question around does, kind of provider, provider competition have impact on overuse? I think, the whole provider element does. I do think, though, that institutions, that when you get to the major issues of overuse, institutions have to make the resource allocation decisions that will either facilitate or ultimately discourage overuse or block overuse. Things like, MRIs and ORs and procedure rooms and space and capital equipment allocation is generally done within the institution. So while there's lots of folks that may want to drive overuse in the provider community, it's and I don't know if it could be that Paul's questions around competition among providers. I guess that might, in terms of we all are trying to be financially viable to continue to compete in the market, and revenue and bottom line and ability to reinvest in oneself is part of that. So I'm sure it is. And then I guess the last thing I would point out, and it was more maybe a reflection on some of the discussion you guys had before I came on, is this, kind of dichotomy that exists in society. I've always found it interesting that, and I think education is at the root of this, as it is with lots of things, but I've always found providers, physicians tend to be fairly conservative with their own care and the care of their loved ones. They don't tend to have a surgery unless they absolutely know they need to have a surgery, because they know that there are side effects and consequences and things that can happen. Same thing about, pharmaceutical use and other things. And then you have a society, and I think our culture in the United States is more about, I need the pill, I need the surgery, I need the imaging, I need the fix, I need it now. And then that's, I think, further complicated by the fact that we have a very poor public health system, which was only demonstrated through COVID, that as in, things varied by state, by county, by employer, by city. We don't know really how to do public health. And frankly, our citizenry does not want public health. If you look at how it's approached in other countries. So to me, that's just a very interesting dichotomy, is you may have providers driving overuse in a society that welcomes it, and they actually don't do it to themselves and their loved ones.
Thank you.
Oh.
Gary, you'll have the last word. I think we're pretty much out of time.
Well, just to comment on the prior question, I think that indeed there is pent-up demand, and there has been pent-up demand for all the reasons that Peter identified, and much of that is legitimate. It's evidence-based. As one of the, as we all know, one of the sad things about COVID was the delay in necessary care. We're seeing many more completed MIs, strokes that could have been avoided if patients had felt comfortable accessing the healthcare system. So we've got those issues. I think that my final comment would be on the role of the public, and I think this is somewhat alluded to in Peter's comments about our culture. I think we've got, and perhaps the Lown Institute is one vehicle for this, I think we've got to have an all hands on deck education of the public about the hazards of overuse and overtreatment, that this is a public health issue, that it is a patient safety issue. We are harming patients. Interestingly, I mentioned our Center of Excellence work with complex spine. Of 100 patients sent to Virginia Mason, told in their community that they need spine surgery and we can fix you tomorrow, 58% are sent back with no spine surgery, and only 1% of those end up having spine surgery. That's an eye opener. Patients come with their suitcase ready for their operation, and it does take time. We have to educate, we have to give them alternative approaches, but I think we need to educate the public, and I think therein will become a major force for what we here are trying to be about, which is embedding appropriateness in everything we do and avoiding overuse and overtreatment. So I hope we can work together to raise awareness out there, not just amongst the profession or the employers or the payers, but also the public at large. Thank you.
Thank you. Thank you, Gary. Thank you, Peter, for joining us.
You guys have just been terrific guests, but also thank you for the work that you're doing at your individual hospitals. Thanks everybody for joining us.
Thanks for everybody attending.
Yeah, you can go to lownhospitalsindex.org/overuse if you want to see all the results. And then on May 25th, we're going to have the launch of our inclusivity rankings, racial, income, and educational inclusivity of U.S. hospitals. So learn more and register at lowninstitute.org/presents. We'll see you there.